Good afternoon. Thank you very much, you all, for coming. I'm so glad that we have here Elizabeth Rojo. First of all, I'd like to thank our partners, the Santa Casa Hospital and Conceição Hospital, to make this happen. Elizabeth is with us this week and next week, together with Dr. Freddie Paris from Porto, to make a course for the medical people or residency or people from both hospitals to learn the basics and a little bit more about scientific writing in the health area. And she was very kind to propose us this talk today that is about, as you know, cultural humility. And I would like to tell a little bit about her CV. Elizabeth is a program manager for the Pandemic Initiative for Equity and Action, working on COVID-19 related efforts. In particular, she works with the California Department of Public Health and several community-based organizations on the creation of a cultural humility module for case investigators, tracers, as well as the expansion of communities of practice across the state. Prior to COVID, she worked in global health and research areas that include HIV, emergency medicine, global health education, and minority aging. Her educational background is in international relations from the School of International Relations in Madrid, where her thesis focused on women's issues in Ghana for the Millennium Development Goals. She has a special research interest in infection diseases and implementation science, and she has worked internationally developing and growing projects in places like Mexico, Tanzania, Ghana, and US. She's Mexican, so she speaks very well Spanish. She speaks also French, and she is now learning Portuguese. So she will be happy to take questions in Portuñol or English, and I'm sure we will have a very nice discussion. Thank you very much, Elizabeth, for coming. The floor is yours.
Thank you, Jennifer. I will remove my mask. Maybe that will make it easier to understand. Bem-vindo e boa noite. Thank you for being here. I really appreciate you taking your time from your day to come. It's the evening, and you've probably had a very long day, so thank you for being here. Please let me know if at any time my English is too fast, or maybe repeat something in Spanish, or if you would like one of my colleagues to translate to Portuguese. So with that, let's get started, and I will ask you all to take out your phones. We will try to make it interactive. So we will have some polls throughout the evening. If that QR code doesn't pick up on your phone, you can go to the website, slido.com, and enter that code. Okay, I think... No, it's not working? Just wait. Okay. I promise it will make it a little bit more exciting to participate in the poll. Yeah? Okay. So let's practice with the first poll. So just let me know how you're feeling today, not how the weather is out there. I know today was a very nice day. But how are you feeling today? What's your mood like right now? It's the end of the day. Did you have a good day? Do you have something positive to look forward after this lecture tomorrow? Let's see. Okay, I can see my results. So I don't know if you can see it on your phone. Can you see it on your phone? Great. Okay, so most of you are feeling warm and sunny, which is great. I think the weather outside actually does have an impact on our moods. So let's keep going. So today's agenda, it's our culture humility training was developed as a response to the COVID-19 pandemic and case investigators and contact tracing. The culture humility topic has been around since the late 90s. However, we saw the need for a culture humility training for the California Department of Public Health, and that's how the training came about, with collaboration with community-based organizations. And so now that is something that we are sharing with it applies to all public health professions, truly, beyond just contact tracing. So we will be seeing a quick intro of what culture humility is. We'll be reviewing a little bit about the principles of culture humility, and then identifying and challenging bias. So when we talk about bias, sometimes there are some triggers that, oh, I forget, I have too many controls. I'm doing my laptop and then I have to do this too. There might be some triggers in the conversation today. So it takes being in the right state of your mental state and having an open heart to receiving information that can be triggering to you. So I'd like to read a quote, and it says, "The fact that we are here, we speak these words in an attempt to break that silence and bridge some of those differences between us. For it is not difference which immobilizes us, but silence. And there are so many silences to be broken." So this quote is by Audre Lorde, who self-described as a Black lesbian mother, warrior, and poet. So now, before we get started, I'd just like to get sort of a temperature check. Can you see the poll on your phone now? Let me know if you can answer to the poll. I'm interested to see how many of you have heard of culture humility before. Are you familiar with culture humility principles? So if you can let me know if you understand the concept of culture humility. Yes or no? And then I see 14 responses. We had 18 responses before. I don't know. I'll give you a little bit more time. Okay. And then, do you feel confident that you can use culture humility principles in your daily work? I see 14 responses, so I'll wait 10 more seconds. Okay, so now the next poll, it's actually a text response. So if you can let us know in 1 to 2 words from what you've heard of culture humility, what it means to you. And there's no right or wrong answer. I know we haven't really gotten into that. But what does culture humility mean to you? And Raul, if we can share some results. Yes, please. They're going to start coming up. So great, I see empathy, respect, acceptance, inclusion, opportunity. Respect and empathy seem to be popular. Competency, inclusion, respect, and empathy. Those seem to be the most popular words that come from this group. I see we still have 4 participants typing, so please do share. Okay, so respect, empathy, and inclusion. Thank you for sharing that. So if we can go back to the slides, please. So what is cultural humility? Cultural humility is defined as a lifelong process where the individual examines their own beliefs, cultural identities, biases, and values, as well as the beliefs and culture of others to create an environment of impact, of respect, and mutual understanding between each other, regardless of our differences. Humility suggests that you will never know everything there is to know about another person. You will never know their entire history, their background, and that is particularly true about the communities that are different from our own. So we might belong to a group, right? We all belong to groups. However, we will never know everything about the other people in our group. And on the slide, you see that it says, it's another definition of cultural humility is relinquishing the role of expert to become the student of the patient, with a conviction and explicit expression of the patient's potential to be a capable and full partner. And those are a few key words there, that your patient's potential to be a capable and full partner. So where does cultural humility come from? That concept. It was developed in 1998 by 2 California, San Francisco Bay Area pediatricians. They are Jan-Marie Garcia and Melanie Tervalon. And they published an article, and I would be happy to share all the resources with you later if you'd like to read the full article. They've published this article about cultural humility and how it compares to cultural competence. And then Dr. Vivian Chavez, she developed a 30-minute documentary based on the concepts that were developed by Dr. Garcia and Dr. Tervalon. And I will also share, it's on YouTube, it's 30 minutes, and I recommend you watching this. So what is cultural humility compared to cultural competency? Some key differences are that cultural competency suggests that learning is finite. It's usually set up as a training that you check off a list. So you go to a DEI, a diversity, equity, inclusion training, and that's done, so then, therefore, you are competent in this culture or in this training that you just took. It focuses heavily on self-advocacy. How are you going to use this competency on this culture, let's say, to advance your career or to advance your goals of your research? However, cultural humility, it's an evolution of that. Not that cultural competency is bad, but it has some limitations. So that's a good start. Cultural humility states that learning is infinite. We are lifelong learners, and that's actually one of their core values. So who you are and who you view the world through your own identity. So it's a lot about critically self-reflection and reevaluating your thoughts, reevaluating how you respond to your patient's needs. It's about peer advocacy and partnership. So it's not just about your research, it's not just about your patients, but how are you going to empower them to bring them to the table and make them equal partners? And it is more than just, it has a definition, it's an approach, it's a philosophy. So you live cultural humility, you become culturally humble, and that's a lifelong learning process. Cultural humility is critical to achieve health equity. Its person-centered care is respectful and responsive to the individual preferences, needs, and values. And it ensures that these values guide all care decisions. So the three principles of cultural humility are lifelong learning and critical Cultural humility sees the other person as an equal, capable, and autonomous person. And that encompasses all of the three principles of cultural humility, which are lifelong learning and critical self-reflection. To practice cultural humility is to understand that culture is, first and foremost, an expression of self, and that process of learning about each individual's culture is a lifelong endeavor, because no two individuals are the same. Each individual is a complicated, multidimensional human being who can rightfully proclaim, my identity is rooted in my history, and I get to say who I am. So with that is recognizing that even if I'm a Latina woman, that doesn't mean I understand all issues of Latina women. Even in my own household, where I was raised by the same parents as my sibling, as my sister, that doesn't mean that I understand who she is fully. So taking that idea away and seeing your patient as that, seeing your partners whom you do research with as that, as an equal, individually individual human being that they get to say who they are, right? The second one is recognizing and challenging power imbalances for respectful partnerships. So while working to establish and maintaining respect is essential in all healthy and productive relationships, the root of effective healthcare practice is in acknowledging and challenging the power imbalances that are inherent in our practitioner, client, and consumer dynamics. So right from the get-go, acknowledging that power imbalance exists between you and your patient by simply having the role of expert, right? So there is a power imbalance there. And institutional accountability in urging that. Organizations need to model these practices as well. So from micro to macro level organizations, they also need to be lifelong learners. Systems change and embodying those changes. So more on lifelong learning and critical self-reflection. Refers to critical self-reflection and perspective transformation throughout the lifespan. A willingness to suspend what you know or what you think you know about a person, a group of people based on generalizations about their culture. Awareness that one's own perspective may be full of assumptions and prejudices. And as culture shapes our lifestyles and beliefs, it is very much affects the way that we take care of ourselves and we respond to health issues. Cultural humility is not a one-time process. It's a lifelong process of examining the beliefs and cultural identities of yourself and others. So no two individuals are the same. And so how can you practice critical self-awareness? You can start by asking yourself, do I offer all my clients, patients, or participants, CPP, the same information and recommendation? If not, what informs this? What assumptions do I make about my CPP based on our conversations and informations that they give me? What are my personal and cultural values or beliefs, and how do these influence my approach to this work? In what ways have fear, lack of knowledge, and systemic oppression, including but not limited to ageism, classism, ethnocentrism, heterosexism, racism, and sexism, influenced my own attitudes and actions? What steps can I take to minimize the effects of this personal bias? How can I use self-awareness to appreciate the multicultural identities of my clients, patients, participants, and colleagues? So critical self-reflection is a start to viewing and evaluating your own beliefs and how you bring those to your work. So recognize and challenge power imbalances. While working to establish and maintain respect is essential in all healthy and productive relationships, the root of effective healthcare practice is in acknowledging and challenging the power imbalances inherent in the practitioner-client-consumer dynamics. So the power or lack thereof has a notable impact of health, and power structures are socially and historically perpetuated. This is particularly true for the field of health. Historical and political narratives contribute to power structures that affect health. These power imbalances come from characteristics such as wealth, nationality, gender, race, and the privilege associated with those characteristics. Power dynamics has been broadly studied in health, and the social determinants of health played an important role in those most affected by COVID-19 around the world. So let's go back to our Slido, if you still have it up. If you haven't logged out, can we share Slido, please? So in your work, can you share with us what are some power imbalances that you see in public health? So thank you for submitting your answers. I see that we have access of information, poverty, culture, social distance, access to quality healthcare, socioeconomic differences, social and economic conditions, education, and access to healthcare. Thank you for sharing those. Also, some examples that I have are the power of the expert, right? Using expert language. That relationship is asymmetrical. The power to provide information and access to services and resources, and that's a symbolic power as a professional inherently in health and medicine. So that is something that just by the simple fact that you are in medicine and you studied this to your patient, there is a power imbalance. And using, being careful about the language and how you communicate their health issues, their health concerns in a way that they can understand will lower that power imbalance. And then there is the power in representation of authoritative institutions. So working for the Department of Public Health or for the government or what university you work for. So those different, the reputation is also a power that we need to be aware of. Okay, can we go back to slides, please? Thank you. So how to balance power in public health. So some ways to do this is to build a partnership with your client, your patient, or participant. Shared decision making. When you do decision making, there are tools to achieve that, and with that is active listening, and there are some motivational interviewing techniques that can help you achieve that with your client and your patient. And assuming that your client and your patient is fully capable of taking ownership of their condition, taking power of making the decision that is best for them with your guided advice. So partnering and building partnership building key components. So we suggest partnering with others to establish a shared vision and goals. Although understanding our differences is important, make sure to reinforce our similarities. And some examples of building collaborative relationships are setting the agenda. When your patient walks into your office, set the agenda. Make sure you're both on the same page about what you will discuss, what treatments are going to happen that day, what is the purpose of your meeting. So set an agenda like we do for our presentations. Negotiate shared goals. So your goal is to have them take their medication, but they're too busy and they forget, somehow it's not a priority in their lives. So negotiate what is a shared goal. Understand why that's not as important to them as it is to you, as someone who's taking care of them. Letting individuals take the lead. They are ultimately experts in their lives, so they will tell you, hey, I can't accommodate that recommendation you're making. What are my other options? And action planning. Once you give them options, say, okay, so now what are you going to do? Focus on the action. So let's plan for this. And then focus on the communication strategy of yes and. So sometimes we hear things from our clients, our patients, that don't really resonate with us, but instead of using no and shutting them off, the communication strategy of yes and will help move the conversation forward and ultimately get to your shared goals. And then institutional accountability. Accountability is literally the ability and or duty to report or give account of on events, tasks, and experiences. So whereas responsibility is an ongoing duty to complete the task at hand, accountability is what happens after a situation occurs. It is how a person responds and takes ownership of the results at tasks. So in your position of power, whatever position that may be, you have that responsibility to call for institutional accountability. If you notice that there's a lack of resources for a certain group of people that you see, that you work for, call your institution out and go to your supervisor, go to a colleague that has a little bit more power to make changes. And that's how you practice institutional accountability and cultural humility. So this graphic that some of you may be familiar with, it's a very popular one used about removing structural barriers. That's part of institutional accountability. It requires self-reflection and critique, which is sometimes not always easy to do or to hear. So you see here what equality looks like, right? It's not always equal for everyone. And then you see equity. So now the resources, the boxes, have been distributed in a way where everyone can see the field, but there's still that barrier. And then we see reality, how in reality things are. So you see there's one person that has a very high stand, and they can see a perfect view. And then you have someone who's in the hole. And then you have liberation, which is really where we want to head towards. Thus, everyone can see from where they're at. Everyone has an equal chance of looking from where they're at. So the impact of historical harm on public health. We can't talk about cultural humility without understanding what's happened in the past and how might we have gotten here. So most of you are familiar with the Hippocratic oath of to help or to at least do no harm, right? But then we see scenarios of histories of harm. And most people have heard of the Tuskegee study of untreated syphilis in the Negro male in the United States, and experiments done in Nazi Germany, in concentration camps. There's also the case of Dr. Marion Sims in the 19th century gynecological pioneer who was only able to achieve breakthroughs by performing horrific surgeries on enslaved women without anesthesia. But these are not all happening in the past. Many are surprised to learn of many other instances of harm done in the name of science and medicine. So having limited knowledge of ongoing and historical harm leads to minimizing the impact. In the US, where most of these examples are from, reports of forced sterilization of women in immigration and custom enforcement custody. This just happened 2 years ago. Women were being sterilized without their consent. There's also happening all over the world in global health, lack of appropriate consent by medical staff for research. Black maternal mortality and morbidity rates are very high in the United States. And I also saw that the rate is really high in Brazil as well. There's racial bias in emergency care and pain management. So what are the consequences of this harm that's historical but also recent? There is psychological trauma. There's medical distrust and mistrust. Distrust is based on a sense that one's trust has been diminished or violated. And mistrust is often a general sense of unease or suspicion towards someone or something that is predicated either on a notion that the provider or healthcare entity may not act in the patient's best interest. And then with that, it comes health disparities, refusing, delaying, or avoiding medication or treatment, and lack of participation in health research. So how does historical medical harm show up in public health? There's information resistance. It's hard to trust when your group of people, if you belong to one of those groups, have been harmed in the past. We see with COVID, vaccine hesitancy or skepticism. And then with that, misinformation based on distrust. So for some, to practice additional self-reflection based on this, on medical harm, how might histories of harm affect your message delivery as a public health professional? So when you are talking to your patient, do you consider perhaps that they are aware of this medical harm done in the past? And are you culturally sensitive to those needs, to those feelings? When practicing cultural humility in your line of work, what might be the hardest part for you? Could it be that you can't relate? Could it be that you yourself are not aware of these historical cases of medical harm? Cultural humility is a lifelong process. What is something that you can do to practice this more mindfully? And how might cultural humility be relevant to your daily work in public health? So how to implement cultural humility? Cultural humility in practice. You admit that you don't know when you don't know. So sometimes admitting that you don't know is the hard one to do, especially when you're in a position of expert as a medical provider or in whatever public health role that you're in. But admitting that you don't know doesn't mean you're less of an expert or you show a lack of intelligence, but it rather shows humility in admitting that you don't know something, and that's really a part of life. And it's also impossible to know everything in our fields. So suspend any judgments that you may have about your client, practicing some home remedies to treat their illness. So we saw this a lot in the US with COVID, and doing vaccine outreach. So I also work and help with training for vaccine communications. Contacts and cases would tell us, oh, I don't need the vaccine, I'm taking this remedy. And so as public health professionals, we want to encourage you to take the vaccine because it's proven that's the safest. But part of cultural humility is suspending any judgments of saying, oh, don't do that, don't take that remedy, that's not gonna keep you safe. It's saying yes and. So yes, okay, great that you're doing something to take care of yourself, but there's also this vaccine that can work for you. And practicing empathy. Celebrating the diversity and the strengths of your clients and what they bring to the table because of their diversity. They might give you things that you didn't think of. And systemically check your assumptions. Check in with your clients and your patients to make sure you're all on the same table and ask questions. Sometimes we might be talking about two different things. So ask questions, listen actively, and be comfortable with ambiguity. If you don't know or it doesn't make sense to you, make sure you let them know. And I'd like to highlight the difference of these three social emotional skills. So we have sympathy. I am sorry you are in pain. That's nice, but it's a little bit distant. And we focus on empathy. I can't imagine what this pain feels like. So it's a shared emotion. But sometimes it's really hard to empathize because you've just never been in that position and you don't know what they will feel like or what it feels like to go through that. So practice compassion. You are suffering and I will do what I can to help. It's connected and it's action-oriented. It doesn't assume you understand what they're feeling because sometimes you just don't. So you can practice compassionate curiosity. It's a way to do the asking, and it's a practice from trauma-informed teaching that asks teachers to ask as non-judgmental investigators so they can better understand students which can also help in public health settings. So the ability to probe for more information without judgment while simultaneously identifying with how that person is feeling or thinking. And compassionate curiosity in practice acknowledges and validates emotions. You get curious with compassion. So consider other perspectives. When you hear something you disagree with, instead of closing yourself to that idea, consider other perspectives. Ask questions, but be honest and humble about your curiosity. This will allow to do joint problem solving. So let's talk about bias. So acknowledging that we all have bias and understanding our own biases. Bias is prejudice in favor of or against one thing, person, or group compared with another, usually in a way considered to be unfair. Some examples of bias are racial, sexual and gender minority, or disability and age. So there's two types of biases. There's explicit bias, which is conscious, and we usually know what those biases are. And then we have implicit bias, which is unconscious. Most of the time, we don't know what those are, and they can run contrary to our core beliefs. So it's important to mention 2 points. We all have biases. It is part of natural human psychology and a normal part of our socialization. And it is common for biases to be completely counter to our expressed values, and they may be deeply rooted. We may believe in equality of all people, but still hold biases against certain groups. So what does bias have to do with cultural humility? Bias can support harmful stereotypes, which is counter to the principles of cultural humility to embrace continuous lifelong learning, where you examine your beliefs, cultural identities, and biases, as well as the beliefs and cultures of others. Those biases can get in the way of our cultural humility journey. So implicit bias is a positive or a negative mental attitude towards a person, thing, or group that a person holds at an unconscious level. So a few research statistics. So our brain holds, we receive 11 million bits of information at any moment, but we can only process 40 bits. And the management of information, our brains create unconscious mental shortcuts that are implicit processes. And the science behind bias is the sorting. So we sort people into groups based on similarities. We self-categorize people, us versus them, or on a personal level, who I am on the group, and in a collective level, who are we as a group? So there are certain types of unconscious bias. There's the affinity bias, which is a feeling or connection to those that are similar to us, a perception bias, stereotypes and assumptions about different groups, confirmation bias, looking to confirm our own opinions and pre-existing ideas, the halo effect, projecting positive qualities into people without actually knowing them. And there's other types of biases as well. So there's appearance bias, there is gender bias, age bias, authority bias, pretty much any group you can imagine type of bias. So bias helps us. Not all bias is bad. Bias can also give us a sense of safety. And it helps us address 4 problems. Too much information, so we categorize quickly. Not enough meaning. We want to give meaning to things, so we categorize things. And we need to act fast. We need to make a judgment in 2 seconds. So we categorize people. And what we use bias to sort out things that we need to remember and that we can discard, there can be some pitfalls to that. So I see that, I don't know if we have 5 minutes to the hour. I'm going a little bit slower, so let me know if I need to. How does bias show up? So it can show up in forms of microaggressions, which are brief and commonplace daily verbal, behavioral, and environmental indignities, whether intentional or intentional, that communicate hostile, derogatory, or negative racial, gender, sexual orientation, and religious slights and insults to the target person or group. They come in some subcategories as microassaults, which are often conscious. For example, name-calling and the use of epithets. They can be nonverbal, so behavioral discrimination such as crossing the street or clutching a handbag in the presence of certain individuals. Or for example, in the case of the United States, a black man in a hoodie. Micro-insults are often covert and unconscious, meant to tear down a person's identity through insensitive comments and the use of stereotypes. So saying something like, "You speak good English," "You're good at math for a girl," or "You're so articulate." Micro-invalidations are often covert or unconscious and used to cancel the thoughts, feelings, and lived experiences of marginalized individuals. I don't see color. That's a big one. It is not a compliment, and it dismisses the experience of marginalized groups. So instead, we should see color, and we should celebrate that diversity. Ways bias can impact public health work. It may influence information and resources that are offered. It could be in verbal or nonverbal communication, and it can impact your efforts in building rapport, and it can be resistance to recommendations. Some impacts of oppression are mental health, depression, low self-esteem, stereotype threat, which is when an individual is worried about performing badly on a test, it will confirm people's negative beliefs about the intelligence of their race, gender, cultural, ethnicity, or other forms of identity. So that's the stereotype threat. It also reflects on physical health, on stress, high blood pressure, and diabetes. So there is research done on bias. They develop at an early age. Unconscious biases emerge during middle childhood and appear to develop across all childhood. So for example, choosing a white doll because it is seen by the media or the world around you as being more beautiful. They have real-world effects. Unconscious biases have real-world effects on behavior. Substantial research has been published demonstrating the impact of unconscious bias in various domains, including the criminal justice system, education, and health or healthcare. Bias may have an impact on hiring and mentoring and may contribute to healthcare disparities. There was a study that stated, based on bias from hiring managers, that just by the names on the CVs, if you had a white-sounding name, you had higher chances of getting hired. And they are malleable, so those are the good news. Unconscious biases can be changed, and you can take steps to minimize the impact of unconscious bias. So how can you reduce your bias? You can practice counter-stereotypic imaging. And in our longer training, we go over each one of these and how to actually impact. But we technically have run out of time, so we're just gonna mention these. There is stereotype replacement, perspective taking, opportunities for contact. So opportunities for contact can be reducing the unconscious bias by increasing our opportunities for contact with individuals from different groups. So this can be achieved by, not just by traveling and say, oh, I've been to Mexico and you've only been to Cancun to an all-inclusive resort. No, you need to go out to town and talk to locals, but you don't need to travel outside of your country to do that. Just go to across the town, check out your local Mexican restaurant, and try their food, and you'll be able to relate a little bit more. And by the way, Mexican food is really, really good, but I might be biased. You do partnership building and individuation. So engaging people as individuals. And then we should also note intersectionality and bias. Intersectionality is a theoretical framework for understanding how aspects of a person's social and political identities might combine to create unique modes of discrimination. Intersectionality identifies injustices that are felt by people due to a combination of factors. So you see all of those factors that really make up who we are, and all of our filters, all of our groups. Those form our own individual culture. So some takeaways from unconscious bias is that it operates on a subconscious level. It runs contrary to our conscious beliefs, and it's triggered through rapid and automatic mental associations between people, ideas, and objects, and the attitudes and stereotypes that we hold. So some self-reflection questions about bias. Why is understanding bias important to public health work or pandemic response? How have you encountered bias in your work? And what are some ways you might be able to practice self-awareness in your line of duty? How has intersectionality come up in your work? And if you want to learn a little bit more about your own implicit bias, I recommend checking out this implicit association test. It came out of Harvard, and it might help you see your own biases that you might not know you had. And lastly, we're almost there, 4 more slides. I'd like to share this helpful mnemonic: to be humble. Humble about the assumptions you make, understand your own background and culture, motivate yourself to learn more about the other person's background, begin to incorporate this knowledge into your work. And remember that it's a lifelong learning process, and there will be some pitfalls. You will make a comment that wasn't very culturally humble, and it's okay. It's part of being human. But knowing and reflecting after that and continuing practicing cultural humility, remembering that it's a lifelong process, and emphasize respect. So now that we have reviewed what cultural humility is, I'd like to poll and ask you, do you now understand the concepts of cultural humility? Can we, please, I think, in case you need to have the QR code again. And all of this is anonymous, so I just see up in that corner how many responses I've had, so. Okay, so I'm going to open the next question. Do you feel more confident that you can use culture humility principles, and contact tracing, sorry, in your work? I still have the contact tracing training in my head. Okay, and then the next one, I would just really appreciate your feedback on this talk and this topic. So if you can just let me know how you would rate how I did today so I can improve. And, let me see. Actually, I will give a little bit more time so we can get to 15. Okay. And then, if you would like to share some additional feedback in actual text of any topic you would like, you would have preferred to have expanded on or maybe included, or something that you didn't think was that important to include. So I welcome all feedback. And can we go back to the slides, please? I'm going to leave that open, but I also want to share, if you happen to be in Boston in November at the American Public Health Association conference, we will be having a longer culture humility training called Improving Health Equity through Culture Humility Training for Public Health Professionals. And I, along with my colleagues from the University of California in San Francisco, will be giving a 6-hour training. And I'd love to see you again there. So with that, obrigado, obrigada, obrigade. Thank you.
Wonderful. Thank you very much for sharing with us this great reflection. One of my tips was that we need some training now. We need a kind of 1 week now training, a workshop on that. Please.
I'd love to.
Let's plan that
Yes.
for the next year.
Let's make it happen.
Thanks for the hospitals for this collaboration. So we are now open for questions either in Portuguese or English or Spanish. Any comments? Any question? Freddie?
Yes, thank you very much. Can you comment on have you been able to follow up the impact of your training? As of now, maybe because of course it's a 1-hour conference, a lot of theory. So if we get into maybe a workshop or something which is more practical, it would be very interesting. But my point is, have you been able to see any follow-up? Because if you've been doing these trainings to health professionals, example, and their attitudes vis-a-vis patients or how they are thinking of practicing, have you been able to do some follow-up and look at a potential link, not results or impact, maybe a link to the training you're doing?
Yeah, so originally this training was for contact tracing and case investigation. So we trained a little bit more, over 14,000 case investigators and contact tracers across the state of California. From that group, several of them have taken the culture humility training. But because of the nature of how the pandemic hit us just so fast and how fast we had to stand up the training, we haven't been able to measure the impact since day one. It was just, let's get this training out and let's share it with our contact tracers and case investigators. We do have qualitative feedback from them telling us how much this training has improved their outreach. So we don't necessarily have quantitative data, but we do have a lot of comments from participants saying how much it's helped them do more outreach and contact tracing. For health professionals, we haven't done follow-up. We did a training with Maryland, the Department of Public Health in Maryland, and there we will be doing a 6-month follow-up to see how the training has impacted. But that was maybe 2 months ago, so we still have a few more months to see the impact.
Can I just add to that? Just to add to that, I mean, that's my point. I was reflecting during your talk, and now that you mentioned and you've repeated the issue of specific groups for the training, like tracking, like tracers, and linked to COVID, I suppose. I think that maybe my point of view is this type of training needs to be targeted to specific populations that are doing specific work, in a way.
Yeah. And that's something that, as we have expanded this training past case investigators and contact tracers, for example, at APHA, the conference, it's similar to the presentation I did today. It's general. It's for all public health professionals. But in order for it to be more effective, yes, if we know it's a group of primary care physicians, or if we know it's a group of contact tracers, or if we know it's a group of faculty practicing global health, then we tailor all of our examples, all of our case studies to whatever role we are training.
And can I just add something to that question? And how often do you think we should retrain or recheck our group?
I think it's a lifelong
learning.
constant.
I know, but is there any special number?
I don't have the answer to that. I think that in our conversations in our group is about, most of us know this stuff, right? It's familiar. We've heard it. We've seen it. It's called culture humility now because that's how we're training. That's the concept that was created. But we've all heard about empathy. We've all heard about listening actively to your patients. But the more we need to reflect. So I think that's the biggest part of culture humility is practicing self-reflection. And that is something as humans we don't really do a lot. So the more we're exposed to these trainings, the more we get into that habit of checking, are we really treating all our patients the same way? So how often do we need that? I don't know. Every year, every 6 months?
And in groups, right? Always in groups, because it's okay. It's a self-reflection that you can do yourself all the time, but I think it needs to be in a group, right?
Yes.
It's important to be.
Exactly. I think a lot of what is learned, it's also from peer and sharing with your peers. And if you have a group to discuss and say, when I talked to my patient about this, or when I did contact tracing, they responded in this way. And the more you share about your experiences, the more you can find ways to communicate. So we do have this training hybrid. So we do part online, 3 hours of our, so for our contact tracers, case investigators, they do 3 to 4 hours online, and then they come to a live Zoom meeting, and they do 8 hours. So split up in 2 days. They do 4 hours and 4 hours, and we do breakout rooms. So in those breakout rooms is where the majority of the learning happens after that initial virtual training.
Okay.
Thank you for your lecture. It was very inspiring. And my question, which kind of research design on this cultural humility issue, is it required to have anthropology research?
For cultural humility research, to practice cultural humility in your research, I think that would help. I think it would. I don't think it's necessary. I think it's something that we are discussing about our researchers at the university, giving them training that includes cultural humility. So they don't necessarily need to design their research project with an anthropology. The word is slipping my mind, but yes, with that background. But if they have the culture humility background, then they can approach their research design in that way. And for those projects, we do focus heavily on partnerships. And when you design a research project, to make sure that you have equal partnerships with whoever you're doing the research with. Thank you.
Any more? Any other question? I was just thinking about our moment here at the university, because we are changing our CV, the curriculum of all our courses. So do you think, based on your experience in California, do you think it would be interesting to have a course, a special course for the students in which phase of the curriculum, in which year? I mean, is there any study on that? How have you implemented that at the university?
I'm not aware of any studies that have that. Cultural humility, there's not a lot of publications on cultural humility. There's not a lot of research done on it. But the conversations that we have at the university about incorporating cultural humility into other trainings, it's been that, for example, for contact tracing and case investigators, we have outbreak management, we have school specialists, and all of them have a module on cultural humility. So how to practice outbreak management with cultural humility. So right now is something that the university is really pushing for, creating more courses for the students. So I think there will be some more specific cultural humility courses in the near future.
Yes, I was just thinking that also maybe a Liga Académica or something like this that we could try to implement, to foster. So Anna, please.
So my question is related, not really question, just a comment related to Jennifer's comment and question, but it's with regards with the faculties, the professors, especially now that we have so many students from all over the country and even from abroad. How could you maybe, have courses for professors to be more prepared for cultural humility?
I think that's great. I think something that's wonderful about the cultural humility training is that the basics of it can be applied to all audiences. It's a few examples how to effectively communicate with the group of people that you work for. For example, with faculty and dealing with international students. The principles of cultural humility are stagnant. Those are the 3 principles. So you can present that material to all of your groups. If you want to focus and specialize in each area, then you can develop scenarios that are specific for the faculty, like how to interact with a student that's from another country, looking at hierarchies. How do they see their professors in their home countries? All of the scenarios can be related to that, to studying abroad or faculty.
Thanks. It was a great lecture.
Yeah, thank you.
Yeah, great. And that she just gave us some ideas for our international committee, right?
Exactly.
This is something that we should practice in our small group and then try to multiply. That's a very nice point. Well, if you don't have... Oh, yes, we do have one more question. In português, yes, no problem. We can translate if necessary.
Tá bom, obrigada. Elizabeth, primeiro, parabéns. Muito obrigada pela tua palestra, excelente. Talvez eu seja a única pessoa que não seja da área da saúde aqui. Eu sou da comunicação e eu venho trabalhando justamente com comunicação assertiva para a área da saúde. Então, para mim, foi uma aula esplêndida te ouvir.
Nós queremos o seu cartão aqui depois, por favor.
Muito bom. O que eu gostaria de saber, que eu acho que é um problema que a gente verifica, como é que tu percebe essa questão do desenvolvimento dessas habilidades socioemocionais, da empatia, desse acolhimento, né, que tu trazes como tão importantes para essa relação interpessoal do médico-paciente, principalmente, quando a gente tem um sistema que está trabalhando contra, que é um sistema que coloca o médico já sentado no computador antes de dar o bom dia, antes de olhar no rosto, que tem que preencher 1000 fichas, que tem que preencher diferentes sistemas, que é uma consulta de 20 minutos. Como é que prepara, como é que junta essas duas coisas? Essa necessidade de humanizar, de reconectar, então, o médico na sua relação com o paciente, quando o sistema está indo contra isso.
Você pode responder em espanhol.
Did you get it?
So I understood a little bit. Maybe let me know if I missed the actual question. So, ¿en español puedo responder? Okay. English? So, what I understood is that how can you practice principles of culture humility when the system is set out to not make it possible when you meet with your patient? Was that?
Yes, because in real life, at least here in Brazil, we have the medical people, they only have 20 minutes time to have, and they have a computer in front of them. They don't even say good morning when the patient comes, you know. So the whole system is made in the opposite of these principles.
Yes.
So how can you change this culture?
Yeah.
Yeah, in the basis.
So it's a tall order. It's going to be difficult because you're talking about a system change. If it's the hospital culture that needs the change, then that's when institutional accountability comes in. So what can you do as an individual? You can be an advocate for your patients. And it starts with having someone to speak up and advocate for their patients. So you can say something in your meeting, in the hospital leadership meeting, that you don't have enough time. Maybe increase the appointment time, or not necessarily increase the appointment time, but provide training to the doctors about how to build rapport with their patient. And it's, I think for something like that, it requires advocacy and speaking up and talking, urging institutional accountability. And there's a training, a research, a health equity research that's being done by my colleagues called Cultivate, that it uses virtual reality to train physicians when they interact with patients. So it's about when they go into the room, how a patient, how the doctor greets the patient standing up or just says hello and quickly, what's going on? And then the virtual reality scenario, as a doctor, you go through it as a patient. So you experience what your patient is seeing. And then it shows you the difference of when the doctor comes in and they actually sit down and talk to the patient. So just changing the level from standing and saying, hi, okay, what do you need, to sitting down and saying, okay, hi, what do you need?
Yeah,
Yeah.
it's very small. Yeah, some little changes that can make a big deal, and also it depends on the mindset of the people. I can imagine also, because flexible mindset. See, people that are here, they are already keen
Exactly.
to learn and to do this movement, right? I wish we could have a full audience, but we have other factors that are implicated on that. But I'm sure we should identify maybe the key people, let's say, the stakeholders
Yes.
from your institution, and then starting by them, and then, but you have to be, so it depends also on the people, on your, not only at the institutional level, but you need to have this engagement of,
Yes.
maybe not everyone at the first time, but you need, I mean, it doesn't mean that you shouldn't start, at least in your sector, or identify at least one group that could be the beginners, right?
Exactly. And we also have a module as part of the longer training that focuses on well-being. So practicing cultural humility can take a toll on your own mental health, because it can be difficult, you know, if it's just you trying to change a whole institution and the culture, it can take a toll on your own well-being. So that's something that we also mentioned, that cultural humility is lifelong. You will fail sometimes, and it will get tiring sometimes, because, you know, we're humans. We also have a life going on, and if you feel like it's an uphill battle when you are trying to urge institutional accountability, then your well-being is also taking a toll.
Yeah, but I know very much this feeling that, well, okay, we do all we can, all our best, and then but the system is always on the other way around. You know, it's always pushing us to the other side. So okay, not just the system, right? So maybe, yeah, sometimes, yeah, it depends on many things. It's complex, but yeah, yes, I agree with you. So that's why it's. You gave us a very good reflection here, and I'm sure we will we will do our homework, and let's talk about that much more in the next months, maybe. Thank you very much, Elizabeth.
Thank you.
We need to close now because they need a small break to the course that will start in a couple of minutes. So
Yes.
thank you so
Thank you.
much.
Thank you so much.
Yeah.
Thank you.